we know that both disease-free survival and metastasis-free survival are improved by the use of adjuvant chemotherapy after a nephroureterectomy in the POUT population, which was patients who'd undergone a radical nephroureterectomy and had had T2 to T4, N0 to N3 upper tract urothelial carcinoma. Now, if they were node positive in the study, they had to have had any visible nodes removed at the time of surgery and then a negative CT scan. What we didn't do was mandate a lymph node dissection. And the reason for that is because there's still very little level 1 data, and there was certainly no level 1 data at the time to say that a template lymph node dissection was going to make patients live longer. And again, we did a survey across the UK to look at what the surgical practice was at that time, and certainly there was no enthusiasm with our surgical subgroup to be mandating that we did an extended lymph node dissection in those patients. So if there was anything seen at the time of surgery, it was removed and analysed, and then the patients, if they were node positive, had to have a negative post-operative scan, and they had to also start chemotherapy within 90 days of their nephroureterectomy. And I think that's quite important. If you've got a disease that's got quite a high rate of relapse within the first 2 years, then adjuvant treatment has to be given within a certain time frame. And I think 90 days is a reasonable time for that. I guess some of the problems are the fact that patients often, it takes some time for their post-operative histology to come through, and then they also need to be seen back in the urology clinic, told their diagnosis, and then referred on to oncology. And that can't be done on day 89, because then we can't see them and get treatment in. Some of the other important things are about the language used when we're talking to these patients. So with POUT, we did a qualitative sub-study, and that's because this is a rare incidence tumour. And what we wanted to see was what were the barriers for patients going into the study. What we found was that actually the main reason initially that patients didn't want to go into the study was because they didn't want chemotherapy. So if it was an option between, potentially getting chemotherapy or surveillance, against what we had thought as clinicians, we thought that they would want chemotherapy. It was actually the reverse. Obviously now we have this as a standard of care. So this is what we would be advising patients to have. But it was also about the language that was used. So we, in the qualitative sub-study, we audio taped with patient consent and investigator consent a number of consultations and developed top tips for people talking, both the surgeons and the urology nurses and the oncologists talking to the patients about the study. And I think a lot of those tips are really useful when you have any type of adjuvant study, or you're seeing a patient off study, because if you say to somebody, well, I've got your results from your surgery and I've got all the cancer out, you immediately shut the window on any discussion about adjuvant treatment. And certainly we found that that was putting people off going into a study. And it's about that language that's used, and that's often, it reflects the unconscious bias of perhaps the surgeon who's seeing the patient. I've done a nice operation, I've got it all out, rather than saying, actually, this is a tumor that does have quite a high rate of relapse, certainly within the next 2 to 3 years. And therefore, what we need to do is to give you extra treatment to reduce that risk of relapse further on top of the study, and that's on top of the surgery. And I think if we expectation set that for patients before they go for surgery, that is the best thing to do. And that ultimately was one of the key messages that we gave in terms of top tips to people who were seeing the patients as part of the study. So we had a 2-stage information sheet, one that was given prior to nephroureterectomy, and then one that was given afterwards for patients whose pathology made them eligible. And that's probably one of the most important things that any of us can do, talking to patients about adjuvant treatment, because the expectation needs to be set well in advance. And that was what our patient focus groups told us at the outset. I think we've answered the question forever now. We answered it in 2018, but there were still some skeptics. So what we've done is we've strengthened the confidence intervals. We've done a test for interaction again. We've shown that it's in all of our subgroups, the width of the confidence intervals is down to the fact that some of the subgroups have got smaller numbers in. But the way that the pre-specified subgroups were set up is such that we were able to test the effect in each of those against the test of the effect for the primary, for the trial as a whole. And yeah, carboplatin has an effect in the same way as cisplatin has. I guess for the purposes of the study, we did stipulate that the only reason to give carboplatin was down to poor GFR. Obviously, that was in the context of the study, and we didn't want lack of efficacy to be due to other medical problems, which is why we were that stringent in the study. And we all know that once you've got a study, you know, a practice changing registration study, then what happens is you start using, you know, those data in other patients. So now I would not limit the use of carboplatin just to patients with a poor GFR. If there are other reasons that I wouldn't want to give them cisplatin, you know, the medical reasons, but they were carboplatin eligible, then I would give them carboplatin now. It was just that for the, you know, for any study, you have to have fairly stringent inclusion and exclusion criteria, and that's what we did at the original setup, which you have to remember, the study opened in 2012. So we're talking 12 years ago when it first opened, and it shut at the end of 2017. But with any adjuvant study, you need that longer follow-up data so that you can be certain that your curves don't ultimately come together. Sometimes they do, simply because, you know, at that point you may have few numbers in each arm who are still surviving due to the lethality of the disease. What we're doing at the moment as well is we're looking at the translational elements. And Rick Bryan from Birmingham and the team at Birmingham, together with the Institute of Cancer Research, are looking at that, with the idea that we can look at things that were over or underexpressed in the patients who had chemotherapy and those that didn't. What I've learned from POUT is that if you have a rare tumour, you have to get the research question right to start off with. So you have to ask the people who are going to be involved in that study at every level. So that's the people that will be recruiting, the people that will be the gatekeeper. In this case, it was the urology team and the urology specialist nurses. And you have to ask the patients and get the design right, because you can have the best scientific question, but if you don't get the design right and it's a study that patients want to do and clinicians want to do, then it's dead in the water. So you have to do that, and also having that qualitative aspect so you can monitor things like the language that's used, so that you can see where there is clinical equipoise and bias, unconscious bias, often with the language that we use when we talk to patients, and that can again affect what, you know, and that can spill over into everyday life in terms of the way we counsel patients, and sometimes we're not aware of it. It's just that the way words that we use can be interpreted in a way that's very different to what, you know, what we think it is. And so it is possible to do rare incidence tumors, and it's possible to do trials with very different endpoints. So surveillance versus chemotherapy are radically different randomizations. But it's a question of making certain that you know that it's the right question and it's one that is clinically meaningful to patients. And then to make certain that you get everybody behind you. So years before we even got the funding for this study and opened, I blagged my way onto every single uro-oncology meeting in the UK. If there was a bladder cancer session on it at a national meeting, I contacted the chair beforehand and asked if I could speak for 90 seconds about the study with the schema of the study. So people thought it was open before we'd even got funding. And that was to keep it fresh in people's mind. And I think as a CI on a study like this, you have to invest you. There is no point in leaving it all to your trials team. So people are much more likely to respond to personal emails from the chief investigator, just saying, look, I can see you're not recruiting. How can I help? What tips have we got that we can share with you? So we had monthly teleconferences with all centres, which myself and my research nurse from Preston, Sheila Calvert, joined in, and the trials unit, so that we could try and troubleshoot and try and support centres, rather than just going, well, you've not recruited. But so that we could actually share best practice and top tips. And I think it's that personal touch and reaching out that you have to do if you've got a low incidence tumour. As I said earlier on, interestingly, one of the reasons why one of the some of our European colleagues didn't collaborate on the study was because they preferred doing a quite complex design, a phase 2 neoadjuvant study, which is called Uranus, which is put to them at the same time POUT was put to them. And just at the time we were opening in 2012, that study has yet to complete its recruitment. We've published twice.